So I'm just going to run through a couple of introductions. I'm not going to put the slides on just you. Oh, no, I will put the slides on, but obviously I will disappear. It's a shame that we can't always see each other. But before I do that, let me just introduce a couple of people that are hosting the session first. So Rachel, do you want to just introduce yourself so everyone can see you? And
yeah, sure. Hi, everyone. My name is Rachel Rees. I'm Head of Primary Care Networks across Nottingham and Nottinghamshire. My key role is really supporting primary care networks in their progress through the specifications, supporting their development.
So Sarah, do you want to just introduce yourself? So
hi, I'm Sarah. Hopefully a lot of you know me. I don't know why on my name it's coming up as Sarah Partridge, but you know, I'm a member of the Partridge family, I presume. So I work at NCGPA as a lead, and I also work at the training hub. I'm here mainly as support, so I'll be manning the chat.
Ooh, right, the agenda for the day, we're going to do some Mentimeter quiz. We've done the introduction, so we've moved that around already. We are going to talk about PCN and where it comes from, and a little about service specifications. I forgot to edit this, sorry. And then we're going to move into some of the IIF indicators. And it's where we go with it is really much going to be dictated by you. So we've got a majority view around certain areas of focus. We'll try and focus on there so we get the most out of the group. We're going to leave a fair amount of time at the end for Q&A when we turn the camera off as well. And that'll give people an opportunity to be very much more specific if they want to, and we can go into a bit more detail. So, right. So I think it's over to you now, Sarah. Do you want me to stop sharing? Will that help? Or yeah, I can read lips, so I'm going to just come off my share. There we go. Over to you.
Right, I'm just getting Mentimeter up.
Right.
So, yeah. We've got lots of people logged on. I've never done it with this many people, so
okay. I'm
quite intrigued to see how it all goes. Oh, I'm liking the picture choices. Just give a bit of a moment for everyone to log on. So who am I hoping is going to win? Right, I'm looking at all these pictures here. Oh, I think I might be going for, I quite like the hamster face. So that one's pretty good. So whoever's the hamster, I'm rooting for you.
I didn't get to pick my picture. I'm Sweden.
Oh, you're Sweden. That's very Eurovision. That's very Eurovision at the moment. I think it's very, very apt. Right, it looks like there's no more symbols popping in. So I'm going to start the countdown. If you're not logged on, oh, there's a few more. If you're not logged on, just feel free to just play along and answer in your own head. Don't give away the answers though. Okay, I'm going to make a start so we don't get behind.
Well, Simon's the hamster, so we've got a clear
Simon's the hamster.
Yeah.
Right, so what does WTA stand for? So World Tennis Association, Worldwide Tennis Association, Whole World Tangent Angle, or World Tennis Affiliation? Oh, we got a mixture of answers. So those that went for the first answer are right. So question 2. What nationality is the first African winner of a tournament at the Madrid Open? So we've got South African, Egyptian, Tunisian, or Kenyan. How's your tennis knowledge? I didn't know the answer to this. Oh, nice split. So whoever went for Tunisian, you're right. Next question. We're now going into the actual theme of the thing. What does IIF stand for? Hopefully you'll all get this right. So Impact and Innovation Fund, Investment and Impact Fund, Innovation and Investment Fund, or Inspired Ideas Fund. I'm going for Inspired Ideas. So the majority got that right. Well done. No one went for my idea of Inspired Ideas. That's a shame. Next question. How much is IIF worth in 22-23 in pounds? So this is in total 50 million, 120 million, 260 million or 540 million? The answer is 260 million, although that's a really tricky question. So well done. 2 more questions left. What does GPES stand for? GP Extraction Service, GP Excellence Show, GP Evaluation Service, or GP End Summary? So it's actually GP Extraction Service, so it's the extraction of the data. So well done, those 13. And last question. What does CQRS stand for? Corpus Quorum a Subpoena, Calculating Quantitative Reporting Service, Conducting Quality Reassurance Service, or Calculating Quality Reporting Service? Personally, I'm liking the Latin answer. Time's up. So the majority got that right, so well done. So in a second, we're going to find out who is the winner. Fingers crossed on the hamster. So the winner is Becky. So well done. Amma and Donna, you both did really well as well. You've come second and third. So well done. Gold star to you. I'm afraid we have no actual prizes, just a virtual pat on the back. And then we've got one more question just to help us guide this presentation today. So which IIF domain are you most interested in? So the tackling health inequalities, providing high quality care, a sustainable NHS, or if you don't know, select don't know.
Well, I'm not sure. Did the vote? Yeah, it didn't let everyone vote, Sarah, on that one. On mine, it said, please ask the presenter to open voting.
Press C, so it should work.
Oh, yeah, it's working now.
Okay, it's really interesting seeing the bars shift.
Okay.
So we had about 52 people take part. So it's looking towards the health inequalities.
Cool.
Which I think is a good steer. Brilliant. So shall I stop sharing now? But well done, Becky. There we are.
So where's Becky? Is Becky here? Look it out. Not used to 3 pages. Here we go. So, right. Okay. Right. I'm going to get on the share. Right. So, we've done that bit. I will just introduce the multi-professional support unit. So something that I've been involved with Sarah for a while now. Sarah's probably had a lot more to do with it, but it's a unit that's been set up to try and support different professions, and especially considering the number of new roles that are coming into primary care. It is in its infancy, and we're always trying to look to adapt and work out how we can help the workforce. So I think it's something just to keep an eye on, really, and hopefully in the future we'll be tapping into people to be able to get some feedback on where you want this support to go, because really it's determined by the people receiving these sessions. And I think the attendance today just reflects that. I think we've got 75 people on the call at the moment. So some of you have seen this slide before, so I went back. I thought I didn't change it too much. So where did PCN start? So it's back in 2019. Yeah, so way back in 2019, before COVID. It was 2000, and the primary care networks began. And I was trying to think back, because I think for me time has been quite weird over COVID, like many other people. I was trying to work out what happened back in 2019. So Notre Dame Cathedral burned down by a cigarette butt from a builder. Theresa May resigned as Prime Minister of Great Britain in June, and there were protests in Hong Kong as well. And the world celebrated Prince Harry and Meghan Markle's first baby, Archie, in May. So there was lots of things happening. I was trying to look at life events which sort of tied in with that, but it feels like such a long time ago. It's unbelievable. So, but where did the idea come from? So back in 2017, the Nuffield Trust evaluated a model which was actually launched in 2015, and it was called the primary care home model. And there was Fleetwood and a couple of other places in the country that were like a vanguard for this type of approach. And they have delivered something really successful. There were areas of high deprivation, problems with recruitment, and they were looking for innovative approaches to strengthen and redesign primary care. And that's where this model came from. And if you look back at some of the statistics from Fleetwood, they're quite incredible. And you look at their progress as a primary care network, and they are much further ahead because they started so long ago. And I would just give one example. So their community pharmacists are helping with the hypertension service. So they have system one access within their community pharmacy. They diagnose the hypertension within their community pharmacy, and they then treat the hypertension in their community pharmacy. And that's how they deal with that side of the hypertension bit of the DES. So you can start thinking about where things might move forward. We've got sites in the country that have done all of this before. But when the Nuffield Trust evaluated what happened and what they'd done, they found a few things. So participating primary care home programs strengthen those interprofessional working relationships. And I suppose that the fact that we've got so many people on the call is a demonstration of that, but also the working between GPs from other practices and with GPs and other healthcare professionals was improved, and it's stimulating new services, and it very much feels like we're moving into that space now. It takes lots of time to establish those relationships, and it needs lots of money and time to support that change, and it definitely doesn't need a global pandemic to help that change. So that's where we are from 2019, and that's where we're heading with that evaluation. So the contract came out in 2019, and it was part of NHS England's 5-year framework for GP services. The DES went live on the 1st of July, and there was loads of issues with it. There was lots of grumblings and this and that, and lots happened to challenge what was happening, and the direction of play. Some of the funding models were challenged, and they were needed to appoint clinical directors, and they could be a GP, a nurse, or a clinical pharmacist. And in the city, we've got one nurse as a clinical director, the rest are doctors, but we have got pharmacists and other professionals taking on that role around the country. But they had to either be the only person who wanted to do it, which was the case in parts of the city, or there needed to be an election where people within those practices voted for that. So, and there'll be a network contract DES each financial year until the 31st of March 2024. Which from my point of view isn't very far away. We've blinked and we're towards the end of this contract, not at the beginning. So that's quite interesting. So Sarah, if you notice any questions, just throw them to me and I'll pause, because I can't see anyone now, unfortunately. But and the whole idea of PCNs is working in a slightly different way. So I've stolen some of these slides. In the top left corner, you'll see this King's Fund information, and it's really around how Manchester has merged health and social care together. It's about bottom up, top down, middle out, and it's all this a different way of working, really, which is more responsive to the needs of our patients, residents, citizens, whatever you want to call them. And today I'm going to be focusing on the PCN neighbourhood working, and those networks are groups of practices which are in a geographic area that have been agreed by the practices themselves and the CCG. Ideally, they're meant to be around 50,000 in population, because that's where the data showed, but we've got networks in the city from 35,000 all the way up to nearly 70,000. And I know in other parts of the country, we've got super PCNs and things like that. And it was all around bringing neighbourhood working. So we bring the care to the patient and make it specific to the patients, but also making the whole system work together. So the PCN fits into the city in this, when we talk about the city, but that's now called the place-based partnership, which is Nottingham City, and the place-based partnerships in this part of the world all fit into the ICS, which is the integrated care system. And it's all around everything within there working together and flowing together and working to common goals. And in this area, we've got 4 place-based partnerships. We've got South, Nottingham City, the north of the county, and we've got Bassett Law, which is going to join as well. So we've got 4 areas, and Bassett Law is just a recent addition. So I thought I'd bring a little bit about money. So everyone signed into primary care networks, and there's funding to support primary care networks. So as part of the DES, there's certain money that flows through. So for network participation, and these are all updated. Each practice receives £1.76 by its contracted weighted population. So that's the practice's money for being involved in a PCN. The clinical director gets some money to pay for their time. But from what I've seen, they work way and beyond the hours by which they're reimbursed for with that pressure they're on. There's core PCN funding as well, which is £1.50 per patient. And that's where all the operational money comes from for the primary care networks. And so there's a lot of pressure on that. And then there's additional bits of money that come through around extended access, enhanced access, care home premiums. There's been a new leadership and management payment which has been brought in, which some of our networks are trying to work with to have network managers. And then there's the additional roles and reimbursement money. And that's where a lot of the people on this call I can see have come from, really, through their employment through PCNs. And that amount of funding changes by each PCN, and it's based on this PCN contractor weighted population. So they work out how much money each person is due. And then there's some additional monies for like the social prescribers, which a PCN can claim for as well for a full-time equivalent. So within the DES, there's some service specifications. So if you sign up to be part of a PCN, you have to offer all of these core functions around this. So extended access, enhanced health and care homes, structured medication review and meds optimization, early cancer diagnosis, social prescribing, weight management, long COVID, cardiovascular prevention and diagnosis, and tackling neighbourhood inequalities. So you can see some new things that we may not have seen in 2019 with the long COVID, but there's some areas of focus for the PCN on where our energy needs to lie. And when we look at these specs, these are core functions of the contract, so everyone has to deliver against these. There's no choice. And I remember going to a King's Fund meeting early on, and they're like, well, who's going to pay for, where's the money associated with all of this? And I've gone through some of the figures from before, but most of the money comes through the new roles. So apologies, the screen's a bit blurry, but on the left column is the PCN size. So I mentioned a PCN will be 50,000 in size. So if you go about 2/3 of the way down the column, it shows you that. And then if you go across, it tells you how much money you've got to spend each year, depending on your population and other indicators, really. So in 22-23, a PCN with 50,000 patients will get approximately £531,000 to spend on new roles. So that's on new staff. That figure's quite a way below what you actually get because of the way that the calculator works things out and some of the issues that occur in the city. So they've got considerable amount of funds to spend. If you look at that figure by the end of 2024, it keeps increasing all the way through, and that's when we're expecting the funding to stop. We don't know what's going to happen after that. And if you look at the top row, it sort of shows you that national amount of money. So by the end of 23-24, they're going to be up to 891 million. I'm not used to reading figures that big. I did get excited this morning, actually. I went on my phone and I'd seen that I'd won something on the Euro jackpot, but it was only £6. But when I saw there was a UK winner, I did get briefly excited, and I started thinking about figures that big. But anyway, but these figures of 891 million are quite conservative when it comes to the city, because I think when we look at some of the figures for our networks in the city, some of that, the spend on staff could almost be double what we can see on that slide. So you see there's considerable amount of investment. These are the roles that you can get. The money on the right here, so you've got the role on the left, the band in the middle, and then the money on the right, and that includes on cost. So it's not the actual salary of the individuals, it does include pension and NI. And it gives you a range of all the roles that can be employed, from clinical pharmacists to paramedics, social prescribers, dietitians, podiatrists. And we've not quite realised the potential of all of those. I know in the city, for instance, we don't have any dietitians or podiatrists, unfortunately. We've just about got a few OTs in the system, no nursing associates or trainees or paramedics. So we've got a little bit to go if we're going to try and enrich the workforce a little bit more. So with regards to workforce planning, your primary care network has to let NHSE, which is NHS England, know what their workforce plans are. And by August, they need to have let them know what their plans are, the updated plans of 22-23, and they need to let them know what they're going to spend next year on 23-24. And that's how they're going to spend the money on these different roles. So lots of information there. I just thought I'd do this slide to just show you what that means for us in the city. So it's just a quick pictorial capture, really. So there's some of our clinical directors. We've got the new DES. We've got Emma Bravery, who was in charge at the NCGPA at the time, who like started all of this off and got it going. And there was lots happening at the time. And a lot of these people volunteered to step into a space where there's lots of unknown. And I always see these people as quite brave, really, especially when you look at the clinical directors. There was no real clear direction of what they were getting into, but yet they stepped up into a leadership space. And some of them are still are not in post, some of them still are in post, and things have moved all the way through, really. So for us in the city, it's been quite a big change. And I think when you look at those columns of this staff, that staff, what that means to me is actually what you do with those staff, because it's quite easy to just pick people off. And I don't think I've got the consent of my staff to put these photos up here, but this is some of the stuff that we focus on. I think it's very important to consider that the DES is a contract, but actually there's lots of people that underpin that, the way that it works. People's jobs are focused all around the delivery of this contract, or have only been created through this. And I just thought it's a important thing to always consider, that there's people involved in this process all the time. It's not just a contract and a piece of paper. So but yeah, I won't dwell on some of those photos. So with the service specifications, we've got 3, 6, 9 areas, and there's a core bit of function within them, and then they've all been updated, and there's some key changes within each of those. I suppose from my point of view, we've got 2 sections within the presentation. Like, so do you want us to go into those changes in the service specifications and what's changed for this year, or do you want to move into the IIF phase, or is there any, or?
We've had a quick question in chat, Ankish.
Okay, yeah.
We move on. So Elena asks, when do we find out about what happens after 2023-24 with regards to budgeting and roles? And there were quite a few people interested to know how potentially it could affect them.
Yeah, Rachel, can I ask you that question? Because I don't really have an answer for that yet. It's a big unknown, so I'd be speculating, but I can speculate after I hear what Rachel says. Hello? You're on mute, Rachel. Was she here, Sarah?
Let me just double check. Oh, she did leave. She's coming back in now, though.
Okay, cool. Straight into a question.
I know, we're like throwing her in the deep end. Rachel, welcome back. We have a question for you about if you've got any idea about what's happening after 2023 with regards to the budgeting and the roles within the DES.
Yeah, sorry about that. I lost internet connection, do apologise. Yes, so the NHS England are undertaking a review as we speak. This next couple of years is going to be crucial with regards to the next steps for PCNs. Obviously, a lot of investment has been put into primary care over the last few years, so it's now and what has happened with that investment, what change have they made, what impact have PCNs had. So that's all going to be taking place over the next few months. We're just waiting for full report to come out very shortly. But with regards to financial investment into the R's funding, we have had confirmation from the national team that funding will remain in situ. So it will continue, whether it continues in a PCN or a different format, or I don't know, but the actual investment into the R's funding will continue.
Well, that's great news, isn't it? We could end right now. That'd be good. So
yeah. So it is key. In particular, these next 12 months, there's going to be a lot of assurance done on PCNs. So there'll be a lot of ask from me, so that I can feed that into the national team. And you know, there has been a lot of really good work that's happened in PCNs. We need to make sure that, I mean, where possible, we do notify region of, you know, different things that have been happening, but we've got to make sure that it gets to the national team as part of this wider review. But yeah, the next steps will be key, but the investment into the R's has been confirmed that will continue in whatever guise.
That's great. So that means that we're safe. I suppose where I challenge some of this as well is that actually what we don't know is whether we're going to continue to get these increases every year, you know, in more roles. So I think what I've been talking to some of our workforce in the city about is really think about your role, what it's delivering within your PCN and where you need that to be by 2024. So if you need a social prescriber in every practice, and that is the vision and the model, then your recruitment plans need to follow that. And I think if you're one of those roles within the PCN, this is a really important time to be stepping up and thinking about what you want your workforce to look like at that endpoint and try and influence some of that decision making, because otherwise every year to now we've had an underspend. We've never spent the money for the R's workforce. So and it can just disappear. It can go back up centrally. We try and regurgitate in some way back into the system, but it just disappears. So really think about a longer term vision for your network around your roles, and not just around your roles, it's around a service. And we're doing some work in the city around diabetes. Think about what collectively we can deliver around some of these agendas that we've got. So I think the slides will definitely be available. I just noticed that. I think Sarah's mentioned that we'll get those across, and I've not gone down my usual route of having just loads of photos, so they don't make any sense to anyone. So Rachel, I'll flick over, but maybe you could go through some of the key changes with the network DES service specification, and that'll give me a bit of time to slow down how quickly I'm talking. Here we go. Right. So I'll hand over to you, Rachel, for this bit.
Yeah, so I think the key, obviously, we've had a very interrupted couple of years due to COVID. So obviously many PCNs haven't, have been doing as much as they can around the PCN specification. But obviously this year, because like I say, we are in the last 2 years, there will be a real strong emphasis of PCNs meeting the requirements of the PCN specs. But this year, there's been a couple of extras that have been added in. The biggest one, as it states on the slide there, is around the extended hours. That piece of work is going to require a lot of support from the primary care team, the whole team, to deliver. So at the moment, practices and PCNs do deliver this already. So you may be involved in, early morning working or late evening working, or even Saturday or Sunday working. So it is already happening. It's just what's happening is, as part of the contract, it is being brought together under the PCN for its delivery. So there's going to be a lot of discussions that will be taking place, and as part of that, I would strongly advise all individuals to get involved in those conversations. We refer to core hours. So obviously you have your core hours as a practice, which is generally 8:30 till 5:30, but 6:30, but this is also core hours within extended access from 6:30 till 8, and Saturdays 9 till 5. As part of the extended access, again, it's a full multidisciplinary team offer. So not just GPs or nursing teams, it can be your link workers getting involved, or your physios, or any of the team can be involved and be contributing to the extended hours. Range of services as part of the enhanced access can be routine as well as on the day. The only thing obviously the PCN has to think about is, if you're working a Saturday, do you have access, and you're taking bloods, can we get the bloods to the hospitals for the relevant checking? So there's a lot of organisational planning that will need to be done to determine what you consider routine services, but all services needs to be offered and available subject to your workforce.
Yeah, and just Rachel, I was just going to say, I think this change is a change in approach that the R's workforce, the additional roles reimbursement workforce, that the roles that should are part of this enhanced access, because you couldn't use them before. So is a patient that's at work, is he, they still may want to see their pharmacist in the evenings or on the weekends. So it's a real change that the whole NHS is offering a service consistently to meet the patient's needs. So it's not just, like Rachel said, a nurse and a doctor that need to be there. It can be broadened out to much of the other roles. So that's why it's important for you to be around the table or have some sort of influence, or discussion around it. So
yeah, and it's important that I think whenever I talk now, I include the wider team. So may that be the R's roles, but also all the other roles that are within the system, because from a workforce perspective, we have to maximise everybody's skills and skills and knowledge to support patient care. So yeah, definitely, where possible, involve the R's roles. I appreciate that individuals will have to talk to the employers and discuss this. So, it can be quite a sensitive subject, but we can all contribute to it in a variety of different ways. The current arrangements that are in place now will continue up to that 1st of April, and then it will then switch to the PCN specification. I can see a couple of the chat questions coming in. Do you want us to answer those now?
I think so. I think it'd be good. Let me take I'm just going to stop my share so we can see each other. It's nice to be able to talk with each other, can't we, when we go through the questions. So, Sarah, did you want to just read out the question, who it's from, and then we can maybe...
So there's quite a lot of questions that come in. So Deepa is asking, do you want to ask, Deepa? Do you want to unmute and ask?
So whilst we are waiting for Deepa, if available, so the full guidance around this hasn't come in yet from the national team. We're still waiting for those final guidance to come in. Unfortunately, PCNs will be asked to complete a plan. That plan will be on a national template. We've been told it will be with PCNs within 2 weeks. That was last week, so week or so away. So it will be kind of a structured thing that requires submission to the CCG. PCNs do have to conduct patient engagement. That can be kind of any existing engagement activities that you use with regards to consulting on those hours. You can do a Sunday if there's patient need. So if your patient consultation said, actually, I don't want late, I also want some extra on a Sunday morning, for example, then, and the PCNs are happy to support that, then that will be supported. So it'll all be based on, your patient feedback. I don't know if Deepa's with us or not.
Yeah, there's quite a few questions there, so it may end up taking too much time. But
yeah,
the question was, there are a few now actually. So let me just go back.
So you've already answered the Sunday one,
yeah.
And the hours, Deepa, I think, is mainly it'll have to be negotiated, and is the locality contract changing then? Is it moving then to a PCN contract?
It is.
Yeah.
So it basically the whole PCN will be responsible for delivery. At the moment, all individual practices get involved. But now PCNs will have to consider the location across the PCN. It's got to be accessible. Obviously, it's got to be open. So, we've got to think about the estate and whether there's any issues around estates to keep that premises open on a Saturday, for example. So the other things that need to be considered is interoperability between practices. So each individual practice has to be able to book appointments into each other's, into these sessions. So the interoperability needs to be there. There needs to be read-write access. You need to be able to see all the full patient records. So a lot of work is required around this, and discussions that are taking place. I think, I don't want to take up too much of your time, because obviously this is really big. This is the first big delivery of service that the PCN will offer. I think, bearing in mind if this works well, and the PCNs, can deliver, that there could be other opportunities that could come down, that PCNs could deliver locally as we move forward through the system.
Thanks, Rachel. So I think
if there is a lot of questions, we can either deal with them at the end, or I can deal with them separately and email those individuals back.
Yeah, we'll do that. I think there's a couple of questions about contracts. I think I'm here representing NATH, so I won't go into that side for NCGPA, but those are, because this is for the whole system, but those discussions would need to be with the employer and PCNs and having a look at the frame of that, and of course it's a mixture and blend, so it's not about using one workforce to just do something. It's about a shared responsibility towards something, and the main thing is patient need. You know, there's no point putting appointments for a certain role there if no one wants to see that role on a Saturday or Sunday, you know. So it's really thinking about what the patient need is and how you quantify that. And but yeah, okay. I think Deepa just apologized to her browser doesn't allow audio, so she wasn't dissing us. It's just it doesn't work. So right, so I'm just going to share my screen for the next bit. So the other key change is cardiovascular disease, which is an exciting bit, I think. Do you want to go for it, Sarah? Sorry, Rachel.
Yeah, so the CVD did come in last year from the 1st of October,
yep.
But it is really being extended this financial year, which is great. The detection in particular of people that are out there in the community that have undiagnosed blood pressure problems. We're trying to capture that through a variety of measures. So in general practice, opportunistic BP monitoring, but also working with our community pharmacy. Community pharmacy have a separate enhanced service through the national team that supports hypertension. So they will be doing opportunistic BP monitoring patients, and they will be liaising with practices on their findings. And there's also a way now that practices will be able to refer patients into community pharmacy to carry out their patients that are already on your hypertensive register for their potential, you know, blood pressure check, nip into a pharmacy, have your BP done on a Saturday afternoon, that kind of thing. So we're also looking at, you know, early diagnosis of heart failure, and obviously the broader foundations of preventative care around CVD, which also then do link into the quality QOF and obviously the impact and investment fund indicators. So there is a lot of work that is happening around the CVD, rightly so, but also involving other work colleagues, like I say, the community pharmacy, as well as your traditional general practice team. Yep. So a lot of work is taking place around the CVD agenda, and our clinical directors have an update at their clinical meeting this week actually on all the things that are available to support general practice and the community in this subject.
And just a reminder that the way this is a core function of the DES. So if you sign up to the DES and you take your £1.76 as a practice, the £1.50, and you sign up and access the funds and the roles, this is a core function around cardiovascular disease prevention, but it does tie in through existing payment structures through QOF, which is quality and outcomes framework, and additional indicators that have been added around the investment and impact fund. And I know there's been a lot of, and this is a personal view, there's been a lot of discussion around whether we'll look at that or not. But some of these indicators are very much aligned to clinical risk. And I think you have to sort of think about what you're going to look at and what you don't, if there's a mandate to look at something, and you need to make a personal decision around whether you are going to look at it, you know, but what are the consequences of not looking at it when everyone around you is looking at it within other practice, or if community pharmacy is starting to do something or not. So it's going to create some very challenging sort of conversations, I think, as we go forward. Right, so let me just check the chat before we go into early cancer. Okay, I think there's something that was emergency access. What I will say is we're talking to community pharmacy, not all of them are providing the blood pressure services. So, so again, it's not totally linked up yet. So some are doing ambulatory blood pressure so that you can refer to them and they will get that done. Some are not. Some are helping with the blood pressure check, some are not. So it's a bit of a patchy picture at the moment, and there's a little bit of work to do to just join all the dots and get everyone at a sort of certain level. So can I hand back over to you, Rachel, about the cancer diagnosis? Yeah,
sure. So obviously during COVID we did see obviously a lot of people not presenting for their you know, their various checks. So this year there is a real big drive on, you know, promoting and encouraging people around the bowel and cervical screening programs. So obviously PCNs do have to look at how they are, how they're achieving against, you know, the people that are due to be recalled in. There'll be obviously a lot of national as well as local promotion of these programs. So obviously we will be looking for practices and PCNs to support that agenda, and especially looking at those that perhaps do not engage perhaps in these programs, and looking at different ways that we can kind of promote and hopefully get them engaged and in for their various checks. Obviously fit tests are you know, being encouraged where appropriate for relevant cancers, and that is also linked to the IIF as well. Teledermatology, bit of work I'm doing actually at the moment is just to understand where we are with teledermatology and what is available for general practice. But obviously we've got to look at using all kind of pathways that are available to us within general practice, but obviously teledermatology has been one in the past. And we're also looking at prostate cancer as well. We've seen, you know, over the last couple of years, in particular with COVID again, lack of people coming forward within this domain as well. So another area that has got a real focus this year, both locally and nationally. But all practices will be encouraged to engage and support in getting the word out.
It's so important, isn't it? I think just a big shout out to like Deborah James. I don't know if people know her, but she's from the Big C podcast from the BBC, yes, where they talk about cancer. And I think she's just gone into a palliative care for a bowel cancer. But I think if you want that bit of human and the compassion and stuff that the people link to this, and listen to her talk about early diagnosis and the impact that has specifically on bowel cancer as well, I think it's really, really powerful. And I think when you look at these things, it's all like Rachel said as well, people coming into general practice for this doesn't always work. We know that, but now we've got a network workforce. We've got people working in the community, looking at different areas, and we can take some of these messages back out into the community and make those links where that happens. So I don't think when we look at these things, it can be really easy to go, oh, that's really clinical, but it's not. This is all around people and how we get them to access services in a more appropriate way. So I'll just move you on to the next slide.
I mean, my plea really, especially on the cancer one, or any of the pathways really, is that if anyone has any ideas or suggestions for getting the community awareness or campaigns, or especially those people with low participation, you know, we want to hear about it, and obviously, you know, encourage your PCNs to think differently, but you know, always welcome to receive ideas and suggestions from anybody. So please share whatever role you are in. We all have a responsibility to encourage and support, may that be CVD, getting your blood pressure checked, through to, you know, cancer concerns or whatever. So we all have a responsibility. So any ideas, please share.
Right, thank you. I'm just going to go on to the next slide, and then maybe after this one, we might just go to a group of questions around the service specs actually. So I've got this, and then the personalised care. So
anticipatory care is a new one this year. So it is a new element to the specification. We've known it's been coming, but what is happening is there is a national plan that is due out early May. It should have been end of April, but we're into May now. So around kind of a focus around anticipatory care. We've got to wait for that to come out, but once that is out, we as a system have to develop a plan of which will identify key cohorts of patients that can benefit from proactive care, look at how we offer and support anticipatory care, look at care planning and engagement around the relevant anticipatory care indicators. So what we need to find out is what is going to be the focus. Once we've got that, we then need to develop that plan in partnership with every PCN and there might be slight differences depending on where the PCNs are across Nottingham, Nottinghamshire, with a view that this plan will be signed off by December as a system, and then PCNs and others, and other people that will be involved, will then go off and then deliver that plan. And we do know that next year's PCN plan and specification requirements will be based on the plan that you have supported in writing. So PCNs will then go off and start to support and deliver based on the plan that you've created. So we're in a bit of a limbo at the moment in waiting for that national guidance to come through. But once it is through, then communication will really kick in. We've already had PCN clinical directors have already had initial discussions last month on anticipatory care agenda. So everybody's just waiting.
Right, thank you. And then personalised care for the...
Yeah, so personalised care, obviously you've already had such an experience around social prescribing, which has been absolute excellent work, and that has rolled out significantly over the past, well, since 2019 really, and much wider than primary care. It's gone into secondary care, it's gone into ED, they're in the cancer wards, they're in MSK teams in the acute hospitals. Obviously we've got them within local authority, but primary care, obviously that is going to continue, and this year's focus is really around really involving your key stakeholders, especially the voluntary sector, to support. And I know that they're already with you, but obviously the voluntary sector, depending on the nature, can be a small group or it can be much a larger group. So we've got to look at how we support the voluntary sector, and look at expanding the service as much as we can with regards to referrals in and referrals out, but very conscious of workforce and the constraints that we have. But leading in on personalised care, we're also looking at shared decision making. So shared decision making has been around for years, but with an emphasis now that everybody's getting responsibility around shared decision making. So making sure that that conversation with that patient is had, and that that obviously patients their outcomes are then reviewed using a validated audit tool to make sure that those conversations were appropriate. So may that be through shared decision making about whether somebody has a hip replacement or whether somebody has a knee replacement, or that shared decision making with regards to that person who's liaising with a link worker and deciding on their next steps going forward. But it's a shared ownership, and that patient has active involvement. So real big emphasis on that this year around personalised care.
Yeah. And just, September's 5 months away. And we've got some holidays in the middle and stuff like that. It will come before you go. I think I love this aspect of this opening, especially with the social prescribing, that really looking at proactive cohorts, being identified by patients with lived experience and being, identified with your partner organisations. But it's not restricted to just social prescribing. And I think what we did through COVID, through whether it was, I know it gets spoken about, we did vaccination clinics in Moss within PCN4, which was amazing, and in other areas, and we took services out into our community. And I think those links and relationships we built, even with others when we were working at the COVID sites and things like that, I think they're the things that will all get pulled in now to really push on these aspects of this. So, but really that main thing of working with our voluntary sector and patient like approved or designed services, that's the direction of travel. That's what it that's where we're moving towards for some of those services, which is quite exciting. So right, I'm going to turn my share off, because I think that's all of the enhanced sorry, not the enhanced, but they're all core functions of a PCN. So if you're in a PCN, those aren't, I might do that, or I might focus. You have to do them, or you're in breach of your core GMS contract as a GP. So you need to be really mindful of that. I think the other thing is we said earlier that the delivery of these is from the R's roles, It's through the additional roles reimbursement scheme. So it's those roles that need to support practice to deliver them. So it's about thinking about where you fit into that agenda. So and how you get involved in those discussions. And don't worry, because everyone doesn't know what to do around some of this stuff. Like you say, we're always waiting for information to come through. No one's expecting miracles, but if you've got ideas, like Rachel says, you start exploring them and working out what you might do differently, because carrying on with the basic model of general practice is not going to help us to deliver this. This is all around changing our approach from reactive to proactive, and looking at how we can enhance general practice a bit more. So Sarah, do you want to go through the chat and maybe share some stuff before?
We're having some really good conversations in chat with a couple of examples of people who've tried to implement some of that thing said.
Can we get them to talk about them? That'd be good.
So we've got Elizabeth and Jackie. I don't know, Elizabeth, are you able to speak up about what you've done in Rushcliffe?
Yeah, sorry, my screen camera isn't working at the minute. Just to say that to identify those patients who are unlikely to have a blood test or a conversation about whether they've got FH or it's in their family, just for all new registrations. I know the question's already on a lot of the registration forms about, have you had a direct parent or a grandparent have any cardiac event, a cardiovascular event before the age of 50 or 60. It's often not completed, and I just thought that would help pick up those people who do need further investigations, just to see if they need statins to try and prevent those early MIs and strokes.
Great idea. So simple,
and it's just quick and easy, and it's on their registration forms already. It's just that nobody completes it. Love that idea. So simple. So effective. And having such a, but just it has a profound, there's such a, the impact of that can't be measured, can't it? Like with regards to just picking up on those people so early on. It's really, really. I was just concerned the IIF doesn't necessarily flag those people that we don't know about. It only, because not many people under the age of 29 have actually had a cholesterol test, have they? No. Definitely not. And after sitting down for 2 years and eating whatever you can in front of a screen, it's probably a good time to start thinking about these sort of measures in a slightly different way. So, yeah. And then does Jackie want to just quickly talk about how they've helped to help with screening and their event? Would you mind just sharing what your role is and where you're working actually before you go into that? Is that okay? So Elizabeth, what's your role and where do you work? So I've just joined Rushcliffe PCN. I've come from the CCG. Along with Emma, we've been running vaccine sites over the last year. So I suppose my background is I'm a nurse, mainly in urgent care. Okay. So right. Yeah, so I've just joined the PCN. Yeah. Jackie?
Yes, I'm a care coordinator for a PCN in Bedfordshire, and worked on the Cancer DES last year, and we'll do it this year as well. And we have 3 care coordinators in our PCN, along with social prescribers and health coaches. And we put our heads together and said we were going to do an awareness fair, an awareness evening, which we did a couple of weeks ago. Predominantly being aware about screening and cancer screening, but we also included diabetic screening as well. And we invited guest speakers. So we got Prostate Cancer UK to come along. Our diabetic nurse spoke. Our nurse practitioner spoke about cervical and breast screening. And we had our local bowel screening hub. They came along. We tried to put a positive spin on it. We're talking about prostate health, but also, the importance of screening. And we also had 9 stall holders, local partners and charities. So we had Macmillan came along, local council with their fitness programme. Boubettes came along to try and help young people to take away the stigma of checking your breast for cancer health. Again, Prostate Cancer UK were there. It was an hour, so the actual event was an hour and a half in total. We slightly foolishly thought we would get sort of 40 or 50 people. We had to stop when we reached 90, because that was our maximum capacity in the venue that we had. So we're putting it on again in 2 weeks' time.
That's awesome. I hope you're moving to Nottingham, is what I'm thinking as you go through that.
Pinch our model. It's absolutely fine. It's really simple. We advertise in local newspapers, local magazines. We put posters up in surgeries and sent SMS texts out to. We ran through reports to find out patients that were late with their screening or hadn't had their screening at all, and invited them as well.
It's great, isn't it? Making use of that GP system, the health data, and that's what it's about, isn't it? You're trying to utilize all your resources and bring them together to do something that ties that in. So
it was great teamwork. It was good fun on the night as well.
Yeah, thanks for sharing that. That's great. So was there anything else? I think I saw something from somewhere else. Just so Chase was just talking about, he did NHS health checks for more than 100 patients last winter. But they won't be paid for them, but I'm not sure I'm going to pick that point up now, but I love the fact that you've done 100 points, checks. And we've got Matt, sorry, Sarah, was there another?
We've just got a comment from Mahua, I don't know if I'm pronouncing that right, I apologise. It's just saying how we need to utilise the full workforce.
Yes, totally agree. And I think, that utilisation of the workforce is about having a focus on outcomes. It's about knowing what you're going to focus on, and the health inequalities data and the information coming through is meant to help build the picture. Once you know what you want to do, then you go and get the roles. So I always talk about Dale Winton, about people that know about Dale Winton and supermarket sweep, and also early days of and that was, I think, on the King's Fund report, that was my a contribution to a quote about supermarket sweep. If anyone sees, that was me anyway. But it's like we've got loads of money to get roles in, and it's just throw everything in without knowing what we're trying to cook, if that makes sense. Like, all the ingredients without knowing where we're going to get to. I think we've got a really good thing in the city where we've got a critical mass of numbers as well for delivery. That's important. But the end point now is really, really important. So as you put your vision together as a workforce, that needs to tie into a broader vision as well. And it's really those types of conversations that are going to be quite helpful. And I think maybe, Sarah, that's our next step for the NPSU, really, to start getting people thinking around how a social prescriber and a care coordinator and a pharmacist and a dietitian or whatever it is can come together to deliver something more effectively, which isn't always going to be based in general practice. So, right. So we're halfway through, pretty much on time. I don't know how people's energy levels are, but I went to some, Emma, do you want to come in? Sorry, before I go into this next bit.
Yes, sorry. Hi, everybody. Lovely to see you all in Nottingham. I do miss you all. I'm working on a project down in Norfolk, which, just because it clicks into quite a few of the areas that you've just been talking about on your slides, it's a place-based project, which is quite interesting, quite challenging, but we're taking hospital discharge as the starting point for the over 65s. Anyone on pathway 0, which means they're discharged home without any care packages in place whatsoever. And then we're using voluntary sector to do welfare calls, following them up a day after they've left hospital, and then connecting into the social prescribing model to see what can be done to improve their quality of life. So the only reason I mention it here was because of, if you're trying to, I don't mean tick a few boxes in a rude way, I just mean if you're trying to get your mindset into how we get through some of this work. There is some interesting projects. Now, this is based on the Living Well project that came from Wellingborough. That they've been running down there for 3 years, and they've done some really interesting work. So if you're looking for some inspiration on how to achieve all these things, I'd highly recommend Googling Living Well Wellingborough, and they've got their own website, and they've got some really good case studies and stuff, what they've achieved.
That's
okay,
awesome.
That was all.
Thanks, Emma. So Emma gave me my job, so if she'd not given me that, I wouldn't be doing this today. So
I don't regret it at all, Ankish, honestly.
Right. Okay, so I suppose, Rachel, so where do we as a group, so Sam, a very small thing, but I'm holding a couple of events at my running club for blood pressure checks. Where are you, Sam?
Hi.
So you just tell us your role, where you're working, and you seem to have some people that are just spectating. You're not in the staff waiting area, are you?
PCN 7. So I'm a pharmacy technician. We've got Ali here as a pharmacist, and we've also got our new pharmacy technician, Simran. So I go to a running club, and I've just been chatting to a few people there and stuff, and then I'm holding a couple of events for just checking the blood pressure and stuff. So yeah, so
Nice.
just a small little thing, but yeah.
Yeah, thanks for sharing that. So Rachel, you know, like we've got people in the room thinking, what can I do? How do I find out? We've just heard some really great examples, some out of area, some in. Where do people go to look for what other people are doing in the country? Because I'm just mindful that I've mentioned Fleetwood, you know, that's an amazing service they're doing with their hypertension because they're ahead. But how do we find what other people are doing? So
it's really very much about word of mouth. So, you know, you may have colleagues or friends in different areas up and down the country that, you know, we're all part of the same healthcare system, and we all experience different healthcare problems or pathways or new initiatives. And it's really about listening and reading and word of mouth. And if we do know of anything that is working well elsewhere, it's about, you know, please, you know, speak up, you know, have a chat to your if you've got a PCN business manager, or if you know the clinical director or your practice manager, or come to me. I'm always available to, you know, learn about new different things. We have an emerging roles group, which is actually meeting this afternoon, whereby we try to look at different ways of working and new initiatives. So it is really about ear to the ground, having a chat, conversations, and telling us, because obviously there is so much that is happening out there, good practice, and also things that haven't worked well as well. It's also good to learn from that. So yeah, please share, and like I say, always happy for you to make contact with me direct.
I think watch this space then, maybe. I think we'll try and look at things where we might be able to get presenters in to talk about what they've done and maybe sharing good practice forums for the workforce.
What we are looking to do is a local platform event conference whereby we showcase some of our local work.
Love it.
In the past, we've worked very closely with King's Fund and a variety of key leaders have all been and supported us with that delivery over the last 2 years worth of conferences. We are looking to do one just basically on the R's roles and what kind of great work has been happening locally. So any ideas, if you want to showcase anything, please get in touch.
Right. So IIF, I'm going to just quickly, IIF is like the dullest thing to present about, but I'm going to go for it and make it as exciting as I can. So the Investment and Impact Fund. Sorry, Sarah, did you say?
I was going to say, I like Simon's comment in chat.
Oh, let's have a look.
He was saying, wave your hands in the air like you just don't care. I feel 21 again. Yeah.
That's what we need. So the Impact and Investment Fund. So points mean prizes. So basically the IIF is there, and it's there to supplement the PCN specifications and also to link in with QOF. And the approach of IIF is very much around building a network, a neighbourhood level response to certain health indicators. So it's important to think about IIF is across the whole PCN. So if one practice doesn't engage at all, there's a potential that none of the PCN will hit those points to be able to earn that cash. So in 22-23, each PCN can earn a maximum of 1,153 IIF points. And the value of a point will be around £200. But even with the points, they're weighted here or there. So it's a maximum, well, it can be around 230,600, it can be higher than that because of some of the indicators, because not every PCN is the same size. There's different levels of benchmarking and things, so it's quite a complicated calculation. And the PCN must provide a written commitment to the commissioners that the money earned through the IIF will be reinvested into additional workforce. So if you do get IIF money, you can actually spend it on a GP. Yeah, you can spend it on other areas, but there are some restrictions within that as well. And you can get equipment or premises and you can reinvest. So it's the first time really that we've had this level of potential earnings from a network-wide indicator. I must say at this stage, I don't think general practice feels at any way ready to be able to look at any additional work. I think we're just about keeping our heads above the water, or we're, you know, or in most cases they're not. They're bobbing in and down, up and down. You know, it's a really, really difficult time. So so where we what I imagine will happen is that we'll focus our energies in certain areas rather than be looking at trying to do everything, because no one's going to manage everything, to be honest with you. It'd be very, very difficult to do. And we expect IIF to increase year on year to a certain degree, but things come in at different stages. So indicators that we might receive that we think are going to be in place for the rest of the year, they tend to stay there, but then new things seem to be added in as we go along. So it can be quite difficult to keep abreast of all of this. There's different types of indicators within IIF. So if you are trying to earn money through IIF, you will have to hit certain targets, and you'll either have to hit qualitative targets or quantitative targets. Yeah. So qualitative being really, you know, the description of the quality on impact. And I think potentially we started seeing things of examples of shared care, shared decision making and things like that. So there are qualitative examples and quantitative are all due to metrics. Okay. So as a bit of a better description, qualitative indicators consist of a criterion or set of criteria. And you, as a PCN, you can either earn all the points available or no points based on where you go. So it's a sliding scale of where you might go. Sorry, not on this one. So you'll either get it or you won't. So it's all around the quality around it. And where there are multiple criteria, failure to meet any of them means that you don't earn anything. So just to summarize, because I confused myself there, is with a qualitative indicator, it's all or nothing. You either get it or you don't. Okay. And then with the quantitative indicators, they're constructed from like a ratio of numerator and denominators, and they're basically in 4 different types of indicators, and these are linked to the different IIF. It sounds a lot more confusing than it is, and I'll probably make it sound a lot more confusing, but actually the vast majority of the indicators are very, very simple, and there's just a few that need slightly different calculations to make things fair in the way that they're paid. So the quantitative indicators, you've got the binary and standard indicators, and that's where you've basically got a performance over a numerator. So you might be a certain number of people having on an asthma inhaler, and how many asthma inhaler checks have you done over the number of asthmatic patients you've got. So that's the type of thing that you're going to get as a binary and standard quantitative indicator. You've got improvement quantitative indicators, and they are based on the change in a relative period. So it's not just linked to figures, it's baselining against what you've already done. And then you've got your composite stuff that brings both of them together. So it makes it a lot fairer from my point of view, that they're going to look at how a PCN might be performing at the moment and how the change is relative to the original performance. Because if you're doing really well already, you may only need to do a very little to get the max amount of money, and this balances that out. Does that all make sense at this stage? But feel free to ask any questions. Or
there are no questions in the chat.
Oh, go on. Oh, okay, that's fine.
There aren't any. There aren't any.
It's probably because they're all asleep at this stage. This nearly bored me.
If anyone wants to unmute and just ask quickly, that's fine.
Okay, I'll keep going. So you get indicators can be up or down, depending on if you want something to reduce in a certain way or increase, which makes sense, doesn't it? That an indicator you might want the target to be lower or higher. And the denominator of each quantitative indicator is the target cohort. So thinking about the denominator, it's always the target cohort in question, whether it's around your hypertensive cough register, it could be your learning disabilities register. So you're starting to think about these cohorts of patients that you're trying to impact. Okay. And that little equation at the top is in the appendix of the IIF, and I've got no idea what it means, but I just thought it is complicated and it's not always that easy to understand, but most of the indicators are just cleanly quantitative indicators, and so you don't need to worry too much about the more complicated ones. And for some of the networks in the city, they are investing in things like Ardens. I know Steve Murdoch is working on F12 to try and improve their way of sort of illustrating how we're performing on IIF. So there is software out there to help. I've been quite pro Ardens in my approach because they have a PCN dashboard. So all practices upload their data into a cloud-based secure server, and then that then processes that information, gives you a dashboard of how you are doing against all of these IIF indicators and where you are in the range of performing. And it can be broken down to have a look at which practices where and who might need a little bit more help, who's already doing well, why they're doing well. So it gives you a really good way of being able to view the data for your network. So I'm quite keen to see that come into place in the city. Things are adjusted as well. So so the way that the finances are done is that they're adjusted depending on list size and also on prevalence. So there are all these types of changes to try and make things as fair as possible. So the purpose of the prevalence adjustment and list size adjustment is to more closely sort of relate PCN payments to the effort that a PCN must undertake to earn IIF points. Yeah. So it's really there to balance things out. So they are looking at the fact that what might be a target for us in the city is not going to be a fair target compared to like as it may be in Rushcliffe, depending on your demographic, for instance, around certain areas. So it's going to be much harder to do something in a more deprived, a more diverse area than it may be to do it where it's more affluent. So, okay, so that's the way to look at things. I've put the links on the slides to these documents. So when you go on there and you get them, you'll be able to go straight through to the actual documents. You can have exclusions and exceptions like you would in QOF. So and the exclusions are always listed with the indicator itself. So exclusions may be applied to some quantitative indicators, and in the IIF table guidance, it tells you what the exclusion is. So for example, so you had 1,000 patients aged 65 and over, and 600 received a seasonal flu vaccination. If a practice's clinical system records that 100 of those 1,000 patients were offered a seasonal flu influenza vaccination but refused it, and it was also deemed clinically inappropriate for another 100, then you would change your denominator from 1,000 to 800, if that makes sense. So you can use the exclusion and criteria to reduce the denominator as long as it is part of what is stated can be an exclusion. Okay, and there's personal care adjustments which are applied to certain indicators as well. So it removes patients from that cohort as well that you might be looking at it, but it's all linked to the individual denominator when it's not appropriate. So and the IIF is separated into 3 domains. I'm hoping I've not lost everyone yet. There's a prevention and tackling health inequalities domain, which has loads of individual markers in there, providing high quality care and a sustainable NHS. Yep. And if I go back a slide, let's have a look. So we had 1,153 points in total, okay? And then they're broken down, those points, into these 3 areas. So your biggest area is the second one. So your first area is prevention and tackling of health inequalities. So you've got 510 points in that, and each point is worth 200 something pounds, roughly. So 287 of those points are in CBD prevention. Then you've got some more points towards vaccination and immunisation, and 81 in tackling health inequalities. And I have just put down the types of indicators. So when you go back to the slides, it will help, but you can sort of see that's a standard quantitative. So they're the easiest types of indicator to understand. And then you've got providing high quality care. So this has got the highest number of points, but the largest amount of sections. So a big section aligned to access. And when you think about the service specifications we mentioned earlier, there's an alignment of the 2. So we're expected to deliver some core work within our contract, but we have got IIF points to help then support that. Same for the anticipatory care. Structured medication review has 82 points. The care home has 76 points. Respiratory care, cancer, personalised care. So you can start seeing how the points are mapping out against the delivery and where the areas of focus are. And the last bit, I couldn't get the formatting to go in the same way, is the sustainable NHS. So that's got 71 points attached to it. Yep. So each PCN is able to monitor its indicative performance against IIF. And you can do that on things like the Ardens dashboard, but there is a national dashboard, which is available that you can look at. So, and everyone can just log on to that and have a look through, and the links for that are through at the bottom here, through this Opta EMEA. The dashboard's always a little bit behind on its data. I think it's 3 months out on some indicators. Sometimes it's a bit sharper with others. And it supports PCNs to understand their local population, health priorities, and the benefits they're delivering. And that's where all the data extraction feeds into, and that's where we used in the Mentimeter some of those abbreviations to explain some of those processes really, and that's all within the document. At this stage, I was just going to quickly stop, see that looked like some chats in there. I was actually going to go into the document and show you some of these indicators, so you can start looking at the indicator within the document itself and start understanding it within the way that it's shown. I'm only going to do a few of those, and then we're going to just go into a little bit of group work for people just to talk about those indicators. So can I just go to the chat, Sarah? Was there anything? Let me come off my share.
No, everyone obviously understands maths because there's no questions about.
I had to get that boring bit done because it helps this next bit. So let me stop my share.
But they're wanting sets of slides, particularly to know how much each area is worth on the points. I suppose to help with trying to work out which areas to prioritise.
Okay, so let me just come off this a little bit. So what I could do with now is I need some help on what indicator you want to look at, and then I'm gonna zoom into that particular indicator, and we can look at the exclusion, how we're going to measure it, and things like that. So if we could get some sort of consensus on an area, do you want to just go into the chat, and then or if we just go verbally and just shout at each other, and we'll go for it. I'm not sure. Sarah, how do you want to do it?
Does anyone want to choose one indicator they've got burning questions around?
So let's start with the domains. So like I said before, we've got 3 domains: prevention and tackling health inequalities, and providing high quality care. So both of those were quite similar in the Mentimeter. So does anyone want me to look at one of those areas within there? So do we look at vaccination?
Cardiovascular is coming up on the chat.
Right. So,
hypertension.
Right, that's it. First one wins. Let's do that. Okay.
And we've also had the question, and this is something that's been flagged already to us, and we were looking into it. Ardens and F12 are coming up with different results. Which
yes.
do we use?
Yeah, I've raised this. I've raised this nationally. Obviously, Ardens has national governance protocols, and they are slightly linked in with the reporting agenda in a slightly different way. But I don't have an answer to that at this point. So. Right, so you keep talking to me about anything that comes up. So this is the document. If you can see my screen, so it came out in March. Everything comes out late as things are changed, and it goes through each of the areas. So it goes through the information that I've already shown you, and I took all of my presentation from that really, and my understanding of it. So it's all come from there. So everything is in this one bit, but obviously my slides will make it a bit easier. And then within there, we've got these areas of personalised care, anticipatory care. So we wanted to go into cardiovascular, did we?
Cardiovascular, yeah, hypertension.
Okay.
Sorry, the chat is making me laugh because they're saying Ardens probably has more experience of extracting the data, and then everyone's commenting when it arrives.
Yes, so we're just at the last stage now of getting it installed. Not all the networks in the city are getting it, unfortunately. So it was very much a PCN decision on how to do that. So
they've got it in Nottinghamshire, I believe, as well, haven't they?
I think it's coming to an end, unfortunately.
Is it? Oh no.
Right. Cardiovascular's in section 3, Ankish.
So I'm getting enough. Thank you very much. Here we go. Thank you very much. So we'll go past the flu. I know this might be making people dizzy. Is the screen size okay for everyone to see it? And then, okay. I'm nearly there. I should have just clicked on the right one, Robin, and then it would have been a bit easier. Cardiovascular. So part of the long-term plan, it commits to the prevention of 150,000 strokes and heart attacks and dementia cases by 2029. So a little bit of information on why this is an area that we want to work on. And it's not rocket science. I think the overall cost individually to that patient of stroke and to the system is massive. So trying to prevent these things at an earlier stage is really, really important. And hypertension is a core factor within that and lifestyle. And I think the other important thing to realize is that we really don't know what our data has shown us. We've got a delay in data because of COVID. We really don't know what the impact of these last 2 years has had. but the data will catch up. As someone said to me the other day, it will write itself. So we'll start noticing what's happening. But when we start looking, we don't know what we're going to find. And I think that thing of once we start looking, we don't know what we're going to find is really scaring people around, I find this data, what am I going to do with it? How am I going to deal with it? How am I going to deliver it? Where's my capacity coming from to be able to address this? But it's obviously a very clinically important aspect of what we do. And if we look at our own governance, I'm not sure how we go about not looking at it. So here's the first indicator. So CVD, the percentage of patients aged 18 or over with an elevated blood pressure reading, that's above 140/90, and not on the QOF hypertension register, for whom there is evidence of clinically appropriate follow-up to confirm or exclude a diagnosis of hypertension. So what is that saying? It's saying that it's patients who've had a blood pressure over what it should be, and they're not on our hypertension register, right? So, and for whom there is evidence of clinically appropriate follow-up to confirm or exclude a diagnosis of hypertension. So that's there. So a little bit on the first bit of the indicator tells you the rationale for inclusion. So it's explaining that 3 million people have recorded readings of high blood pressure. How many of them are being treated appropriately, but how many of them have not had appropriate follow-up to confirm or rule out a hypertension diagnosis. So that is the crux of it, really. Yeah. And how much has that been exacerbated during the pandemic with people not having blood pressure readings? So this indicator is here to encourage PCNs to follow up more patients with an elevated BP, including through proactive outreach where possible, and to assess them for hypertension, either through the ambulatory blood pressure or home blood pressure monitoring. It's a standard quantitative indicator, so it tells you what type of indicator it is. So it's the most basic, where you've got your denominator and the cohort above, the numerator and denominator. It runs from the 1st of April, so it's already begun, and it ends on the 31st of March. And our denominator for this is the number of patients, this is the number that goes at the bottom, is the number of patients aged 18 or over, so we've got an age requirement. They're not on the QOF register as of the 31st of March 22, and they have had a recorded blood pressure reading in the 2 years prior to the 1st of April above 140/90, or they've had a blood pressure reading of 140/90 on or after the 1st of April. Okay, so that really has given us the range and the scope of the patients that we need to be focusing on. And there is, you know, it's not that easy to sometimes find all this data. I can understand why we want a consistent way of doing it. So when we're looking at the denominator, so of the denominator, we're looking at the numerator now. So of that cohort of patients, we need to look at the numerator. So it's those patients for whom there is evidence of clinically appropriate follow-up to confirm or exclude a diagnosis of hypertension by the 31st of March 2023. So this is what we need to go and do. Within the first 6 months of the first elevated blood pressure reading, they've had 2 pathways. Yeah. So follow-up is for patients that have had a clinically appropriate follow-up, includes the initial blood pressure readings below 140/90. So it's only relevant for patients within that first bit of them having it within the first 6 months, or their blood pressure reading has gone above where we want them to do. So then we're either going to need to change their medication, or we're going to have to organise further monitoring of their blood pressure. I feel like I've confuddled that a little bit. Does that sort of make sense around how we're trying to look across the two, or speak to me? So silence. Okay.
Feel free to unmute if you want to say something.
So basically, we just, anybody with a blood pressure greater than 140/90, we need to have either changed their medicines, get them back in, BP needs to be lower, or arranged home blood pressure monitoring,
Yes.
or adding to the hypertension register.
Yep.
Yeah. So just actually making one of those actions.
Yes, that's it. Finding them is going to be it, and then following them up with the right course of action, basically, and then coding everything in line with this indicator, and then it sort of builds onto them. So then it starts looking at percentage. Oh, sorry, here are the other actions. Apologies. So they've either got a subsequent. So once you've organised that blood pressure, they might have a subsequent occurrence of home blood pressure monitoring, or you'll need to put them onto the QOF. You might have some patients that are sent for same-day referral for specialist assessment, or you started them on therapy. Sorry, yeah, so you've answered the other bits there. Let me just make that a bit bigger. So they're your actions once their blood pressure is high.
Can I just ask a quick question? Sorry, it's the 6-month thing. So take a patient, for example, they've had their blood pressure done pre-pandemic. It was over 140 over 90. It's now post-pandemic, or not really, but you know what I mean. But it's been greater than that 6 months. So if we get them in and have a follow-up blood pressure and it's below the 140 over 90, does that satisfy that criteria and we don't need to do anything else?
Yeah, that's correct. Yeah.
Fine.
So, but
sorry, just wanted clarity on that because of that 6 months. I'm thinking.
But it can't just be a single reading. So it has to be in line with the home monitoring or ambulatory blood pressure.
Okay, so we have to loan them the monitor or have them do the monitoring at home. So we get their home reading plus a clinic reading. Yeah. And then that satisfies that criteria.
Yes. Yeah. Brilliant. So you've got to have that average of the ambulatory to be able to satisfy it. So to not treat them and take them off so they don't.
Fabulous. Thank you.
Yeah. Okay. And then
couple of questions in chat.
Yeah.
Can you, Claire asked, can you show us where the list of exclusions for each group of patients we say?
Oh, yeah, so we're on that page here. So here we go. So the exclusions for this, and the exclusions are all individual to each indicator. So the exclusions for this are patients receiving end-of-life care.
And then Mandip asks, is there any exclusion for 80 years plus because their target is slightly different?
Not as of this, no, not within this indicator itself.
Okay.
Yeah.
And then, so Akeem is saying, is there an age cap? And then Elizabeth has also said, there's some chat going on because the community pharmacy spec is for people over 40. But apparently,
absolutely. Yeah, this is 18 or over. And I think we've also got, we know we've got added things around blood pressure for frail patients, very frail, and different targets and things like that. So there are differences within this, but I think I suppose this is aimed at that cohort that are not diagnosed. So I suppose it's bringing into question, like, where do you think the majority of these people are going to sit within that demographic? So I think there are going to be some outliers within this, but this is aimed at I think a much different group of patients within our population. So
if you look at the upper threshold as well, it's only 50%. So yes. I think that can factor in that not all of your patients are going to need to fall into that.
Definitely. So that's really important. So as we look through, we've got our exclusions, which are patients receiving end-of-life care, okay? And then we've got some personalised adjustments, which we mentioned here. So patient declines ambulatory or home pressure testing. And then we want the direction of travel to be upwards because we want to see an improvement in this. But then, and like Robin says, we've got our thresholds. So our lower threshold is to get 25% of this group of people we find in one of those options, and the higher threshold is 50% to achieve the 71 points. So that's a maximum, it's not a maximum, the upper threshold of half of the patients that we identify. And then some of those patients we identify are going to be excluded. And there's going to be some of those people that have got these personalized care adjustments as well. So is that okay? So, and then additional information before I come to Robin as well. So BP readings and clinical follow-up can occur in general practice or in a community pharmacy and will still count towards achievement of this indicator, provided this activity is coded in GP clinical systems in accordance with the business rules. So like Rachel said earlier, we know community pharmacy has a cardiovascular aspect of their contract. So we really need to link in with our partners that we're going to be able to absorb this work, because where else will it go? It can't just all sit within general practice, and there's other parts of the system that'll be able to support us. So Robin, did you want to just come in there? Because putting your hand up really helped because it popped up on my screen. So
I just want to ask a practical question in terms of payment and reaching the targets and falling within those thresholds. Where do we need to sit within that sort of range in order to get sort of the full payment for that? Is it just sitting in between that, or do we have to hit the 50 in order to get all payment? Or if we're below that, do we only get a fraction? How is that figured out?
Yeah, so my understanding was you have to hit the upper threshold for the full payment. And then it's a sliding scale down to the lower threshold. Is that okay?
Yeah, thanks.
but that varies depending on the type of indicator. So it does get more complicated depending on what we're looking at. So, but this was, if we go back up, it was just it was a quantitative indicator. So, right, there's some other chats as well. So, are there any exclusions? Well, yeah, it's difficult, isn't it? So, local pathways. Okay. So don't forget, we're aiming at people here that are not on the hypertension register. So I think you have to put that into the context of people that we've not fully identified, and it's people that may have had an elevated reading that haven't been treated. So we've got to put that into the context of that. These are people that are unknown to us, or we may have chosen not. I suppose when I was first training, sometimes I'd take a blood pressure in and I'd go, oh, look, they are this. And sometimes the answer would go, well, actually, it's just a little bit over, don't worry about it. Okay. So this is how we're going to address the people that may fall into that as well. So, right. So hopefully that clears that up, that we're looking for patients that are not on the register. So coming back into the screen, because hypertension is very clinical. Not everyone would have followed all of that. So, but looking at the indicator, what I was hoping to do was break down some of the fear. If you look at the way that is presented within the presentation, it really does talk you through each bit and breaks it right down. And the further you go down into it, the more sense it makes. Because after my sort of warbling at the beginning, you can see the other bits coming in straight afterwards, which helps sort of clarify bits of it. So. Is there another one that you wanted to look at, just to get used to the format of the document? Or
so Darcy asked if we could maybe look at the care home, could do some on the care home ones.
Okay. Right. So let's share again. I would love to say this is a strong point for me, but it's not. So we're going to work this one together. So. So this is in the enhanced health and care homes. So the number of patients 18 years or over and recorded as living in a care home as a percentage of care home beds aligned to the PCN and eligible to receive the network contract DES enhanced health and care home service. So we know for a while within the national service bet that there's an expectation of a weekly sort of visit. This is a standard quantitative indicator. And this, what the rationale is a successful delivery of the enhanced health and care home service by PCNs requires the accurate and complete recording of care home resident stays in the GP system. But however, a significant number of care home residents in England are not recorded as care home residents in the system. So this indicator recognises PCNs for more completely recording resident occupancy in care homes, which are aligned to them. Well, that seems quite straightforward. Yeah. So we've got a denominator, which is the number of care home beds aligned to the PCN, and the numerator, the number of patients aged 18 years or over and recorded as being in them. So suddenly we've got the number of free beds we've got and the number of our patients that are in those beds, which is nice and easy, isn't it? Okay. No exclusions, which should make sense. No personalised care adjustments. We know it's an upward trend. There are thresholds and 18 points. Okay, and the way they're going to get the data is from the CQRS is manual submission for your practices, and then the numerator is going to come from the practice extraction service as it identifies the coding for those patients that were within a care home. Okay.
So the PCN could get about approximately £3,600 for making sure that they're coding that a patient is a care home resident. Is that right?
Absolutely, yeah. And here's your denominator. Here are all the codes, a bit more information. So now you know for all of your patients, by linking these care homes to them. And I think someone mentioned something quite important. It's really easy to do the people that are in our care homes. Where the processes go wrong is when they arrive in our care homes. And I know that screening questionnaire that was put into, that someone mentioned earlier, so I've forgotten your name, but having the right process of what you do when someone arrives is really, really important. I know PICs have care homes, care coordinators, and there's lots of different models around the country around how the arrival of a patient and how we support patients transitions through care homes and out sometimes. That sort of service can sometimes help with this type of stuff. So that's really straightforward. I'm going to move straight on. So the next indicator is percentage of care home residents who had a personalised care and support plan agreed or reviewed. Okay, so the indicator rewards PCNs for strong delivery of personalised care and support plans, which is a key element of the core contract. It's a standard quantitative, they're your dates, and your indicator is percentage of care home residents aged 18 years or over who had a personalised care and support plan. Okay, and your denominator is the number of care home residents aged 18 years or over. Okay, so now you know that the previous indicator is going to feed into this indicator to a certain degree.
Am I right to just jump in a sec?
Yeah.
All it is we are linked with quite a few of the PCNs in our area in Bassett Law. We have regular meetings between all the care coordinators.
Yes.
And we're all starting these PCSPs within as allocated care homes.
Right.
What it is we've been on a few meetings and everyone's telling us different about who is actually meant to complete these PCSPs.
Right.
So the first one was that the actual care home staff complete them with the families because they know the patients. They already have all that information. They've got all the care plans, so it's easy for them to do it and get the information to us.
Okay.
We were then told that it was the GPs that needed to do it, but it's going to take up a lot of time to be sending GPs out to get these completed because it's quite a lot of information on them.
Yes.
Then it went to ANPs. That was again the same situation.
Yeah.
So I know one of the surgeries are looking at their care coordinators doing it, but we've recently had a discussion as a collective of care coordinators that the information on there is actually quite clinical and advanced for our role to be dealing with. So we were just looking for guidance as to who actually goes out and like gathers this information for each patient.
Okay. I think I had an answer, but someone's put their hand up, so let me come off the screen, and then I think Elizabeth was going to say something actually. So Elizabeth, were you going to answer this question? Or?
I was just kind of going to give an idea of what we do in my practice.
Right.
So in my practice, we have the primary care practitioner who is a registered paramedic who does the ward rounds for the care homes. And she's been the one that's been doing that piece of work. So she liaises with the clinical lead in the care homes and has been doing it for each patient. So when the care homes obviously do their intake, quite a few of the information, they already fill that in. And then obviously the PCP can then do the other bits based on the clinical information we have. And then if there's anything missing where, I don't know, they need like a mental health assessment or any referrals, then that get passed on to a GP to do.
That's great, thank you. Yeah, we were looking at a paramedic at one point, but that was just before the AMPs got brought up to do it. So yeah, I'll pass that back to us managers about having a look at paramedics for it.
Yeah, I mean, what I'd add to that is I suppose it's not that it's a paramedic, it's about the person who's doing the ward round. So I think that's the key bit really. I think their time is going to be pretty precious, and it's around how different people put that document together. So I think if the care home is a certain level of filling in what they should be filling in, and it's clearly defined what they should do, the care coordinators then can probably add another level of that because they're access to the GP system. And then you've got other clinicians, and it can be pharmacy technicians around certain aspects of it, pharmacists, it could be, and it's that weekly ward round clinician that would need to then finish that off. But I think it's going to have to be an approach from multiple people, so it doesn't all fall on one person, but making it really clear who should be doing what really, and then it sounds like you're about to head into that type of discussion. When you go into this document, everything that you might want to sort of know where people are referring to are within this bit here. So information and best practice are within the Network DES. Further advice can be found within the Care Provider Alliance. And I found the Network DES quite helpful actually, because it sort of defines the weekly round. And around what needs to be delivered, and then we can start looking at who can do what. But I think you just need that, that delivery with the care coordinators, and what you're describing is very much an MDT approach towards that support. And I think that's where you need to have that form filled out in the same way, but being really, really clear about what everyone's going to do. So
yeah, that's great. Our plan anyway was for the care coordinators to do all the inputting.
Yeah.
And we would be using the care coordinator template, actually filling out the PCSP, so they'd all be under our names, but it was just the actual gathering the information and having those discussions with patients, because I know a lot of them are quite in-depth questions about, you know, preferences when it comes to end of life and stuff.
Yeah. So in Mansfield, with the pharmacists, they do all of the respect forms in the care home. So they have specific care home pharmacists that are employed by the PCN, and I think I think there's this acknowledgement there that the pharmacists are really good at completing them, and then they'll go through to the GP or the clinical lead for that part of the service, and they'll do the final sign off. So I think it's just finding what workforce you've got available, and also what workforce you might want to introduce, because I think if you recognise these gaps in these other models, then you might want to go, actually, what we need as part of this is this person to come and help us with this. But if we go into the next indicator, and I'll just do a little bit more on this before, because we're coming up to 10 to. So it's the mean number of patient contacts as part of the weekly care home. So this is the first time really that they're going to be checking. So now we have to log, how many of the visits that are happening, and they're using the coding to determine that. And then there's a threshold now, the mean number of patient contacts that are made for care home patients. So you can start seeing now that actually there's going to be a little bit more around, like what Rachel's saying, around the monitoring. And I can only see that aspect of the monitoring of the PCN DES increasing in that way, where the ICS and other people are going to start looking at our delivery and using the data that we use to monitor us. And that's going to happen across all of our roles and across the core contract to the PCN. You know, it's just, you can start seeing it within this. So, right, Sarah, I'm going to stop talking. I'm not going to go through any more of those indicators because I've looked at them enough.